Hello, in this webinar, we're going to discuss various case studies looking at our clinical experience of the use of the balance tutor. Okay, Amy, so on this patient here, um, you've probably had many of these patients in the past. He's doesn't look too old, but he's actually in his 70s. And he just became stagnant, didn't want to go outside, didn't want to go for walks, just a couch potato, if you like. One of the reasons was that he felt that his balance ability was decreasing and he felt unsafe. So right at the beginning, we've just here got some traditional functional outcome to see what his actual ability is, so that we got something to compare it with. But you have some functional or some outcome measures in the balance tutor as well, which we can talk about later. And what we're doing here afterwards is, if you like, because there's no underlying indication, it's almost like a proprioception and very much a sensory integration training, if you like. So we're challenging him to a mixture of perturbation, both in standing and in walking in all different types of directions. And I think we can introduce as well some vestibular training as well, because maybe he hasn't got an underlying indication, but obviously, there is some sort of sensory decline. So we can look at both proprioception and vestibular as well. Do you want to just outline what your experience has been with these type of patients who haven't got an underlying indication, but just general decrease in their balance ability?
Yes, I've had several patients that are like this. And it does come from most of my patients, it does come from inactivity, such as being the couch potato. I also have another group of patients that have increased anxiety and a fear of falling, and I see the same type of pattern. So whatever it may be, it still needs to be treated, which is really nice, because there's definitely some, as you mentioned, some decreased sensory input, whether that be sensation, vision, vestibular. It could be a whole bunch of things, but these patients do well with perturbation training. They do well with repetition. They do well with getting outside there, with practicing. And then for the anxiety patients, is focusing on something else other than what they're afraid of. So I always tell my patients too, when you're sitting on the couch and you're watching TV or you're doing whatever, I'd like you to turn your head at least side to side during commercials. Or can you get up and walk around the couch, because we need to keep that vestibular system healthy. And inactivity is a great way to kind of just depress or make that system not as sharp as it should be. Mm-hmm. So this up training is going to be excellent for them. And I think it's great that these patients seek help, because sometimes we're wondering, what is the diagnosis? What is it that he has? It has to be, something truly, maybe horrible or, really in depth for diagnosis. But in actuality, these patients just need to be reminded, their system needs to be reminded of how to walk again, how to balance, how to be comfortable, and increase that sensory input.
And often a lot of the referrals are actually coming from the family themselves who are getting worried. They can see it, and not necessarily the client themselves, who might be set in his ways already. Okay, this is another client. Also, this is a stroke client, but obviously a lot less ability client we have here. Why we've introduced this into the presentation is that we can show that he's actually using an assisted device right at the beginning, whether that's to gain his confidence or whether that's by choice that we wanted to do that. So obviously it will limit his reactive response, because he's going to very much involve his upper extremity in the reactive response. But there is going to be some type of reactive response. And the other thing is, again, we're training to his limits. So that mechanical movement with the center of mass, you can see it actually affecting, it's actually is initiating some sort of movements. Yeah. And another point here as well, when you're looking at trying to support with the patient, is we actually have the remote control as well. So we can stand behind the client and give some manual support. And this is quite interesting when you do have a low ability client, because rather than just initiating perturbation and then having to stop the machine as the patient falls into the harness, as here, okay, to actually maybe help him up. If I'm actually on the platform myself, he can actually fall and I can push him immediately up. So I can increase the intensity, the number of perturbations that I can do. And I'm not always limited to, oh, he's fallen into the harness, he now has to recover. I might have to help him recover, or it's going to take him time to recover. So I'm limiting that amount of recovery time each time. So have you had any opportunities with low ability patients and actually using some functional aids with them?
Yes, as a matter of fact, I have a severe ataxia patient who has just a hard time with the hip synergy and controlling the trunk, which really offshoots her balance, so to speak. So this is very helpful. She has a kind of more of a platform walker where she puts her elbows in it, but it's just so she can stand upright. She certainly can walk. The problem is that exactly what you see there is that if she loses her balance, she has a very hard time recovering. What I love about this video is that this gentleman, when he falls backwards, the harness, he gets that sensation from the harness, but then that's a cue for him to stand upright, where that's a hard thing to teach somebody in the clinic, because normally we would grab them if we had a gait belt on them and try to pull them up right there. So he's standing, of course, but this way, this gentleman and our patients get to learn that, in time, if he keeps doing that with repetition, that he can stand up a little sooner and try to get that balance, just because it will be improved. And that's my experience with this BalanceTutor, is that the repetition is key, so that brain can finally adapt to that stimulus. So as you can tell, you can see Avi is not, the therapist is not running towards him to try to save him as he falls backwards. And that is, that's very important to note, just because so many times we want to push stop on that treadmill because he's falling. We don't want him to get hurt. However, it's that critical moment that he feels that harness, that he goes right there. Oh, I got to stand up. I got to stand up. And there he goes. So
that's right. That's a brilliant point, and I haven't seen that point before. So maybe when I'm standing behind some of my clients, I should occasionally let them actually feel the harness and let them fall once or twice within that repetition. Okay.
That's what we do. We let them fall a little bit into that harness, feel it, and we'll give them verbal cues actually to stand up, or put weight on your right foot or left, whatever is appropriate to that patient at that particular time.
Okay, excellent. So this is a stroke patient. Okay, this is an example of an intensive period of rehabilitation, an intensive period of rehabilitation. The client came to us actually for 3 weeks, and we gave him 2 sessions of BalanceTutor a day. Okay. So we're also working on the upper extremity as well. So he was actually receiving 4 sessions of therapy per day, but 2 of them were on balance and gait. Okay. And there's just a comparison of what we managed to achieve. You can see that there's less circumduction. Okay. He's walking now on an uneven surface, whereas before he's walking with a stick. In the office space there. So Yeah, so you can see the difference and of that patient. So, do you have any experience of working with intensively with any intensive periods of rehabilitation with the balance tutor?
Um, yes, I find that video impressive that he could walk on grass
Hmm. Hmm.
after treatment. Um, we do have several patients. One is well, not one, but we have a group that are head injury, just a TBI. And then we have other neurologic diagnoses other than strokes. We have a Parkinson's person that responded extremely well to this type of training. Um, it's it's very impressive. I see how he's still looking down, which is
Yes, I noticed that. I noticed that as well. Yeah. So I'm just what I mean by intensivity is really more frequently than just once or twice a week. You're actually trying to get some intensiveness going in that way. Yeah.
Um, I have a patient currently, and so does one of my other therapists. We see 3 times a week just for this type of training on the BalanceTutor. Uh,
Okay.
I also have a patient who I'm in Montana, but they fly up from Texas to use the BalanceTutor, and we actually go on the BalanceTutor twice a day for about a
Okay.
week at a time.
Okay. So
And
that's the type of intensivity. Yeah. So when they're actually, internal sort of like interstate tourism or when they're traveling, yeah, that they can actually increase that in number of sessions that they're actually doing.
yes,
Um, when you said about the patient looking down, I don't know whether you've had experience, but we've actually installed a camera, so we can actually give it's like a mirror. So almost on the patient screen there, they can actually see themselves as well, and I can direct the angle of the camera, so I can direct it down so they can see their feet. So I want them to be able to try and look, into the screen rather than relying on that visual input, that extra visual sensory input that they're doing. Um, when you see patients looking down, obviously you try and give some visual cues as well, yeah, trying to get them correct.
that's correct. So even if a patient needs to look down, we do have them try to look up for at least 3 to 5 seconds and then look back down and look at their feet until they feel comfortable looking back up again. But
Mm,
we do try to break that pattern a little bit, just so they can see their surroundings, where they're going, things of that nature. And it also helps train all systems even more when you're not looking down at your feet.
of course, I had that reminds me of an elderly woman that I had, and she was just before she was going on holiday. So I said, "You got to start looking up because you got to see what you're seeing. You're going on holiday, and you're not going to look up. You're just going to look at your feet all the time. You're not going to see anything."
Right.
So, okay. Now this is an MS patient. She's a very young patient. She's 27 years old, and I think um, um, she was diagnosed originally probably about 2 years before this video was taken. Okay, so at the beginning of the video, you can see that she had very difficulty doing tandem walking or walking, even in a straight line, let alone, standing on one foot. Okay, and here we have the periods of rehabilitation that we're doing both in standing and walking. Something of interest here is that we can understand is if you go back to those original or the introductory slides that I gave you about the reactive response being initiated by midbrain and yeah hindbrain rather than the frontal lobe and the proximity of the cerebella. So we know that the cerebella is very much involved as well. So the fact that you've got ataxia or MS, then this is, if you like, directing that sensory information directly into those areas, okay, which are involved and which have deficits. So we can actually see why reactive response is going to be of benefit to these type of patients. And then you can see her at the end of the treatment, obviously walking on her own. You can see the uh, width, the stance width is very much reduced as she's walking. Okay, and you can see her now, the comparison, being able to stand on her own, whereas she couldn't before, stand unaided, if you like. So obviously you've had examples of ataxia because you mentioned it. But do you want to comment on some experiences that you've had with patients? Maybe I actually also had a Friedreich's ataxia patient as well. So that was quite interesting. So
Yeah, I appreciate her at the beginning here, just because it looks like she's just having a hard time feeling where center is, and it's not consistent. I see that in a lot of patients. I also appreciate that right there. I was going to comment on that. I love that because we've all done that with the BalanceTutor. We give it too much of a perturbation initially, and they, almost fall. And the nice part is that when you take somebody like this on the BalanceTutor, you can take any diagnosis. You need to make sure it's a success for them. So when we get the correct level of perturbation, they feel more confident that they can take that step. And so what I find is that I might start off a little lower and then repeat that several times, then increase it to where I feel it's very therapeutic. But at that point, I do highlight their successes so that they feel confident and they come back and they feel like I'm making some progress. So it's really interesting. She's finding her center there more.
Mm-hmm.
She's definitely playing with it a little bit more. She does reach up to touch that treadmill a little bit, but all patients do that. And then at the end, after this, you can see when she walks, she doesn't need to touch the wall. She doesn't need to use any of that. She weight bears very nicely onto that left leg.
Yeah.
Things on the right. Mm-hmm. That's nice.
Yeah. You can see some of the inversion on the right foot there when she was walking up and down. So that's something that we can target as well. Yeah.
Yes, that's so incredibly improved.
Yeah.
Was she falling before or no?
Yes. She had regular falls. Yeah. Yeah.
Okay.
Okay.
Yep.
So this is an interesting one, just to show that obviously we can use it with children. We have the children's harness here. So this one is designed for children. Well, for even up from 3 years old, 4 years old. It's a very small children's harness. Okay, and the fact that you can actually on the treadmill at the same time, giving confidence, or put a parent on the treadmill as well at the same time, is useful. Obviously, what we're trying to do, the objective is trying to get her to walk on her own, and you can see the smile, which is a nice smile that you get there when she's actually achieved that objective and walking on her own. Yeah. So there's a couple of things. You can either look at a patient with low ability like this, or actually talk about experience you've had with children.
No, that's great. We don't necessarily see children such as that age in our clinic. However, we do see younger kids with concussions. And we do use this for reactive training for those types of patients.
I think the next slide is, this is an older child here. And we're looking at, there's there's a clinic in the UK. There's two therapists in the clinic, obviously. Yeah, they're working very much on bimanual tasks at the same time, keeping the kid interested, keeping the child interested. We've actually turned the client round here. Okay, so it opens up the whole of the area. So it's a much bigger open area that she's working with, or working in, if you like. Okay, so any comments about the techniques they're using, or?
No, I really like the techniques they're using because you're doing, you're multitasking, so to speak. So her focus is more on throwing the ball and seeing if the aide or therapist can catch it, and she chuckles if the ball goes away. So my point being is that when you have somebody walking on that and you add a small perturbation, it's more real life because she doesn't really know it's coming. And so I like the fact that she has to multitask or dual task is a good way to put it.
Mm-hmm, mm-hmm. So we can set up that in perturbation initiation in a number of ways. We can do that on a time trigger, or we can do it on a COP trigger, or we can do it now with the remote control as well, with the therapist doing it with the remote control. So you can quite conceivably do this with one therapist in the room. There's no problem with that at all. Yeah.
Right.
And then the next one is okay. So I thought it was a concussion patient, but this is actually a client. So it's orthopedic injury, if you like. It's recurrent ankle sprain. Okay, so it's a younger girl, and she came in with us complaining of, within a 6-month period, she has 2 ankle sprains. Okay, so what we're particularly, obviously, the level of training is at a much harder level of training as well, and we're using the what did you call it? Not the biomanual. What did you say you called it? Multitasking. So obviously the multitasking, and I think here we have to look at why are these strains occurring? Is it the fact that we have this inability to do this reactive response at the times when we really need it? So it's not going to be that we have a lack of strength, okay, and it's not going to be something that strength that we can train with voluntary with voluntary exercise practice, because it's really a reaction. It's, again, we have to train it to do that burst speed, that maximum strength, that maximum speed, and that, if you like, is a protective, I suppose, a protective response. And also we're training this protective like reflex response, if you like, to stop the ankle. So that's a couple of things that have really gone through my mind. Anything that went through your mind? Because I know when we spoke earlier, you spoke about how you gave a in-service to your therapist, actually getting them to think about using the BalanceTutor for these type of patients.
That's correct. My therapists were very open to it and very excited to expand their ability to put more patients on there. But I currently have a woman, an older woman, she's about 70 with right knee pain. And I put her on the BalanceTutor just yesterday, and I gave her a perturbation, but I told her which direction it was going to be. And then for the next one, I told her what direction it was going to be, and I by accident pushed the opposite direction. And, she still stayed standing, but she goes, "Oh gosh, that was unexpected," and her response was very interesting. So the difference between expected and unexpected perturbations can be great. I like the fact we're showing an unexpected perturbation, because this woman on the treadmill needs to make the corrective responses to stay standing, whereas my patient had to do the same thing, but she didn't know. She always told me in the past that she would have fallen if it's something unexpected. And the fact that she stayed upright and was able to utilize her right knee, which was the painful knee, was an eye-opener for her. It also was a little bit eye-opener for me insofar as she definitely needs some more training on it. But the unexpected perturbation with multitasking or dual tasking can be very, very effective.
Okay. This is a client here that's, well, not really a client, but post amputation. And we discussed a little bit about, obviously, he's got to, if you like, map out completely a new map of his lower extremity, and understand what to do, a new set of reactive responses, to learn from scratch. And obviously, it's a challenge, if you like. You're pushing that plasticity, actually being able to give that intensive repetitions of the perturbation, actually push that plasticity process in work. Any comments on that sort of training, whether you've had experience of it or how you think that works in various levels of the brain and his rehabilitation?
Right. I early on in my career, I've been a therapist for 30 years. I used to work with amputees. However, I have not had the pleasure of rehabbing anyone on the balance tutor with that have amputated extremities. But that man clearly is working on a very effective hip synergy there to make sure that he obviously there's no sensation below the knee, but he's very effectively training and figuring out how to use his new legs. That's real life thing. This is real life training, meaning that it's so much better to have them off balance and figure it out here on the treadmill than it is out on the street, because sometimes these patients get a little shy and they like to stick to a wheelchair or somewhere where they're just very comfortable.
Mm-hmm.
This is so effective in training real life
That's right.
experiences.
So obviously that's a younger patient, but I had a personal experience with an older gentleman in his 70s who he had some sort of an infection of the stump. So he was back in the wheelchair for a long time. And then he got back with his prosthesis, and we trained him on the BalanceTutor with that. Again, just strengthening. So that wouldn't be like a remapping. It's just getting his strength back again, sort of thing, a real rehabilitation about getting his strength back again. So that's my experience of working with a patient with amputation.
That's great. That's
Okay.
great.
And then this is the sports injury guy. This is in a football club in Spain, Real Sociedad. So obviously you're looking at trying to challenge at the highest ability. It's not it's still rehab, okay? So it's not, if you like, coaching or training. We've still got a patient returning from injury. And again, I think it's this, we don't want him to re-injure himself straight away when he goes back on the field. Okay, so it's what is causing that re-injury has to be some sort of a lack of that reactive response. So that's what I think we're aiming at looking at here. What any ideas, anything more than what we said before about working with orthopedic patients?
Yeah, I appreciate taking a high level athlete, who you would look at that video and almost say, he's doing so well, I don't know if he really needs anything. However, when you compete at a higher level or you're an athlete, those athletes are prone to injury if their reactive forces are not exactly on, because they are working hard, moving fast in their sport or whatever they're doing, and there's just the slightest, being off can cause a hamstring pull or such, so it can lead to other injuries. So this is very, very important. You can see that he's carrying weights, which could throw his balance off even more, which make it very difficult with the perturbation, but he seems to be doing well.
Mm-hmm. Okay. And finally, this is a lady very much to your own heart, because obviously your speciality with vestibular training. So we discussed this lady before, that in the series, in the lecture series, we discussed her, or not really? That you said she had obviously quite good ability, actually being able to do that amount of fast or head movement and VOR work. Yeah. So what would you like to discuss with this slide?
I appreciate when you when you introduce dual tasking for her, she seems to be, such as taking the pen from one hand and placing it in the other and tracking it with her eyes, she seems to have a little bit more difficulty. So just adding such as that, there you go. She has more difficulty maintaining her balance and walking when you introduce another task where she is not necessarily thinking about maintaining her balance fully. She's also having to track the pen and put it in the other hand. So those type of activities can be so beneficial to train not only the vestibular system, but we also have the other postural reflexes, such as the cervical spinal reflex. She's doing the cervical ocular reflex with the vestibular ocular reflex. I mean, there's so many things that are taking place there. I also like the fact that when she's walking, she's also using her vestibular system insofar as that forward progression, moving forward. So the vestibular system has to work with semicircular canals and other parts of that vestibular system. So it's very effective training.
I know anecdotally, after 20 minutes of this, she was very, very tired, very, very tired. You could work with her for, generally doing some perturbations, obviously a lot faster moves, speed of walking, a lot higher intensities. But once you started to work, and trying to work on that vestibular system, then it fatigued her very much. So obviously we were doing something because
right. Yep, that's more difficult, but she's working at it and she's hanging in there.
Yeah. That's right. Okay, and she's actually got a movement biofeedback sensor on her head with the movement biofeedback. You have that installed at your clinic?
We are getting it. As we were supposed to get it last month, but we're going to be getting it here in just another month.
So it's a question again of multitasking, correct? And controlled head movements as well.
Right.
And then this is the slide or the video that I thought came after the video when you talked about concussion, because this is actually a concussion client as well. And again, what we're doing is bimanual task, multitasking, maybe moving that ball, over the midline, from hand to hand, and introducing the complexity of the task, and then giving the perturbation, and then initiating the perturbation as well. Do you have anything to add at all?
Just with concussions, we're fortunate enough to have the neurocom as well. So we do know on day 5 after their concussion, that's when their balance is typically the worst. That's when they score the worst on the neurocom. But then, technically sometimes we see the patient right away, sometimes we don't. So this task would be very difficult if we started them right away on the treadmill, on the BalanceTutor. However, after day 5, this is typical of what you would see, that they're having a little bit of problem with their balance, and they're trying to coordinate that along with control their symptoms. So this is, and you can see when he adds that perturbation, he chuckles because he can't quite figure it out yet. So excellent training right out of the gate. And we want to get these people up and moving. We don't want them to be sitting on the couch and, trying to rest off their symptoms. The day of laying, still in a dark room is over. We're trying to educate our physicians here that we need to see them sooner than later so we can do this type of training and get them back.
So where are you getting your referrals from? Are you getting your referrals from the coaches? Or...
we get a lot of our referrals. Just one is word of mouth. Number 2 is we did send out our complete concussion protocol, which includes a BalanceTutor training on there. to over 500 physicians in our area, and now we're inundated with these types of concussion referrals, which is very nice. I think it's important again to educate the public and educate your physicians and referral sources that you do have a concussion protocol in place, including time on the BalanceTutor, and then to make sure that they know how effective the BalanceTutor can be in restoring reactive responses that are necessary for return to play and return to learn and return to ordinary life.
Mm-hmm.
So,
Well, are they mainly young football players, or is it a broad spectrum?
correct. And I've had patients that come in that are his age, that are sports related, and then I have their parent coming in because they were in a motor vehicle accident a year and a half ago, and they never, they're having the same symptoms that their child is. And I said, well, you never rehabbed your concussion properly. So then that patient comes in and we do similar activities, but definitely the BalanceTutor is probably the center of that because they don't have that reactive response, which puts them at risk for a higher fall rate. So, and I find that these patients, this concussion patients too, if you don't do this reactive training, I will have, prior to having the BalanceTutor, we would have these patients come back in, these concussed patients, because they have had 2 ankle sprains since their concussion. And when you look at that, you have to keep in mind that the ankle sprain can definitely be coming from a decreased reaction time. Not that they're falling, but the fact that they are rolling their ankle and are not able to get that out in time or have that stability is key. So sometimes we overlook the fact that, you just had an ankle sprain, no big deal. But actually, you have to look at the reactive responses that we get here. You have to look at their system and make sure that that's all intact and good.